Welcome to our Group 3A presentation on billing, insurance, and financial considerations for our primary care clinic in Cotter, Arkansas. Our group consisted of Carlton Purvis, Haley Wiley, Katie Bowman, Katie Harville, and Verley Thompson. In this PowerPoint, we'll review the rural Arkansas payer landscape, Medicaid, including managed care dynamics, Medicare, and private payers, and share practical strategies to maximize reimbursements, reduce denials, and stay compliant with state and federal regulations. The following are some of the services that our board-certified nurse practitioner offers: diagnosis and treatment of medical disorders, prescription of drugs and treatments, ordering and interpretation of laboratory and imaging tests, and, when necessary, referrals to specialists. Insurance credentialing is the process of validating a provider's licenses, certifications, malpractice coverage, and practice information so they can join payer networks and billing services. For Arkansas Medicaid, Medicare via the CMS PECOS system, and private payers, clinicians submit payer-specific credentialing and enrollment applications, provide required documentation, and undergo primary source verification, with process times taking typically several weeks to a few months and a periodic recredentialing thereafter. A Counseling for Affordable Quality Healthcare, or CAQH profile, is a centralized electronic record where clinicians maintain licensure, board certifications, malpractice coverage, education, practice locations, and other credentialing details. Payers use the profile to verify information and pre-fill enrollment applications, helping streamline credentialing and reduce repetitive data requests across multiple plans. Our clinic already has established profiles. In Arkansas, nurse practitioners must hold an active Arkansas Nurse Practitioner license, national board certification in their specialty, and, where required by state law, a collaborating physician agreement, along with malpractice insurance and a DEA registration if they prescribe controlled substances. For credentialing practices, submit verification packets to each payer, including Arkansas Medicaid and Medicare where applicable. Undergo primary source verification and enroll the nurse practitioner in network plans with ongoing recredentialing to maintain eligibility. The credentialing process can take anywhere from 60 to 180 days. In Arkansas, nurse practitioner's prescriptive authority is earned through a collaborative practice agreement with the physician, and it is not automatically independent. The agreement should define scope and supervision. You'll need a DEA number and must use the state's prescriptive monitoring program in credentialing/enrollment with Medicaid/Medicare and private payers. This can take several weeks to months while aligning with current statuses and board requirements. In order to actively practice medicine, the nurse practitioner is required to renew their APRN and RN licenses every 2 years, along with providing continuing education hours. A nurse practitioner is also required to renew their registration with the DEA every 3 years. Maintenance of CAQH is required every 120 days in order to keep things updated and accessible to insurance companies. In modern healthcare, understanding the billing system is crucial for compliance and reimbursement. This clinic offers primary, geriatric, pediatric, behavioral health, point of care testing, telehealth, and community education. Different billing requirements and suppliers apply to each area. This simplifies who charges what and ensures services are charged efficiently. Later, we will cover billing providers, how services are divided into care kinds, and instances of billable and non-billable activities. We will also demonstrate how team-based treatment improves paperwork and invoicing. The workshop is relevant to multidisciplinary practices that wish to maximize reimbursement within payer regulations. You should understand how to match clinic roles, duties, and billing procedures after this presentation. Why a dedicated billing service? To reduce administrative burden, improve accuracy and compliance, accelerate reimbursements, and enhance patient satisfaction through transparent billing. Managing billing internally can be time-consuming and prone to errors. Our dedicated service aims to handle these complexities, freeing your staff to focus on patient care. The patient's registration process will begin by gathering insurance information, verifying eligibility, and confirming coverage. They must verify individuals' Medicaid and Medicare status monthly, as their coverage may change. Every procedure executed or task finalized on the patient necessitates precise charge capture and coding application. It is essential that these treatments are billed and submitted accurately with their CPT, ICD-10, and HCPCS codes. Ensure the utilization of suitable modifiers for Medicare and Medicaid billing. Upon completion, send a claim submission online through a clearinghouse, such as Availability, Change Healthcare, etc. Upon submission and processing of claims, payment posting and reconciliations must promptly record EOBs and ERSs and reconcile daily deposit logs. Denial management through the monitoring of denials by payer and rationale. Devise a strategy to mitigate and decrease rejections. Patient billing and collections will provide transparent patient statements. Our process is streamlined and transparent. We ensure each step is handled professionally, reducing errors and delays. Who can bill? Understanding qualified billing providers. Not all primary care clinic workers can bill patients. Professional credentials and payer rules, including CMS and private insurance companies, govern billing. MD and DO doctors can charge directly under AMA. Nurse practitioners and physician's assistants can bill separately or under a supervising provider's NPI, depending on the state's scope of practice statute and payer contract. Licensed LCSWs and clinical psychologists can bill mental health services, notably therapy. Telehealth providers must be certified and use telehealth billing codes. All billing staff must know the provider, credentialing status, and payer-specific billing standards. Billing will depend on medical provider and CMS or insurance qualification. Billing in core medical services. Core medical services include primary, geriatric, and pediatric care. Most preventative chronic disease and wellness services are billed by medical doctors, nurse practitioners, or physician assistants. These providers may bill themselves or through a supervising physician. Pediatricians and family physicians provide pediatric services. Coders 2023 confirms that pediatric nurse practitioners can conduct these under their NPI. The same regulations apply to geriatric care documentation and invoicing, with qualified practitioners recording their visit and complexity. Medicare occasionally mandates the nurse practitioner and physician assistant billing obligations through a supervising physician. Both require correct invoicing and reimbursement documentation. Knowing which patients a provider can bill will help code and bill services correctly, minimizing denials and maximizing revenue. Outsourced option for billing services. According to the AAPC, if you chose to outsource your billing, you would need a third-party billing service company that understands Arkansas Medicaid and Medicare rules. They will also need to be familiar with the Cotter Primary Care Clinic or the clinic you are working at's policies and procedures. It is recommended that they are able to offer credentialing help, denial management, reporting in AR or accounts receivable follow-ups. Key considerations when billing. Accurate billing starts with verifying patient coverage and understanding each payer's policies. Always document thoroughly and seek authorization when needed. Keeping current with regulations prevents denials and ensures compliance. This chart is an example of services, fees, and codes you would provide when submitting services for billing. Billing for behavioral, telehealth, and testing services. Licensed clinical social workers, or LCSWs, and clinical psychologists can bill for therapy services within their licensures and documentation standards. Telehealth services are limited to accredited medical doctors, nurse practitioners, and physician assistants utilizing appropriate CPT and POS codes. Payer-specific rules need safe platforms and virtual visit documentation to avoid claim rejection. Overarching point-of-care testing, or POCT, usually a fast diagnostic test or glucose monitoring service, must be invoiced by the supervising provider, usually the doctor. However, some labs can bill immediately. Guidelines must be followed to avoid billing errors and claim denials. Thus, providers and billing staff must coordinate to properly use modifiers, codes, and documentation in all services. Non-billable versus billable community health activities. Some beneficial medical treatment is not reimbursable and does not help a claim. Due to the lack of a chargeable treatment plan, community education workshops like Chronic Treatment Management, or CCM, and Diabetes Self-Management Training, or DSMT, cannot be invoiced. As long as scope of practice and payer standards are met, nurse practitioners can bill well child checkups through their NPI. LCSWs should also offer reimbursable and verifiable therapy sessions if documentation is successful. The supervising physician frequently charges POCT, including fast diagnostic tests in clinics. Billing needs strong collaboration between clinicians and billing or other staff, strict charting, and knowledge of various payers. Distinguishing outreach from clinical services is crucial. Clinics that provide community-oriented care are more efficient, compliant, and financially stable when they know which services are covered. For any missed appointments or for less than a 24-hour cancellation notice, a $50 no-show fee may be applied to your account. ICD-10 codes are used to indicate a diagnosis, while CPT and HCPCS codes indicate procedures or services rendered. These codes are submitted electronically to insurance companies for compensation. The provider documents the visit. A coder will assign the codes to diagnosis or procedures and submit them to the insurance payer. Then, insurance pays or denies the claim based on the coverage provided by the plan. When it comes to billing, the process varies depending on the patient's insurance type. For Medicare, we'll use standard coding, ICD-10 for diagnosis, CPT for procedures, and HCPCS for supplies or medications. Claims are submitted to Novitas, which is Arkansas's Medicare administrative contractor. Payments following a strict fee schedule and are based on medical necessity. Arkansas Medicaid also uses ICD-10 and CPT codes but pays less than Medicare. The clinic must be enrolled as a Medicaid provider, and some services like imaging or referrals may require pre-approval. With PPO plans like Blue Cross or Cigna, we'll bill through a clearinghouse or their web portal. These insurers pay based on our contracted rate. They offer more flexibility, and patients typically don't need referrals. Now let's look at what we bill versus what we're actually reimbursed. Regardless of insurance type, we bill using CPT codes for services and ICD-10 codes for diagnoses. However, what we can charge is not always what we get paid. For example, let's take a level 4 established patient visit, coded as 99214. We might bill around $150, but Medicare pays a set rate, about $115, and the patient is responsible for 20% unless they have a supplemental plan. Arkansas Medicaid reimburses even less, typically around $80 to $90, and usually doesn't allow balanced billing. PPOs like Blue Cross or Cigna offer higher reimbursement, up to $160, but only if we're in-network and contracted. HMOs often reimburse a bit less and may require a referral before authorizing care. Some use capitation, meaning we're paid per patient, not per visit. Third-party payers like auto insurance or workers' comp can reimburse more, but often require more paperwork and payments may take longer. One key legal note: we cannot balance bill Medicare or Medicaid patients for the difference between our charge and the allowed amount if we're in network. For PPO and HMO, it depends on our contract. Recommended billing software. There is a variety of billing software available to assist with billing and allow it to be a streamlined process. All of the billing software mentioned above, like Cario or Advanced MD, all support multiple payers, EDI submissions, and denial management. Technology and security. We leverage cutting-edge technology to keep your patient data secure and ensure timely, accurate billing. We do so by the use of secure, compliant billing software, integration with EHR or electronic health records, data encryption and HIPAA compliance, and real-time claim tracking and reporting. Medicaid is a joint federal and state program designed to assist low-income individuals and families with healthcare costs. Because it is state-specific, coverage details and eligibility criteria can differ across states. Medicaid generally covers a broad range of services, including hospital care, doctor visits, labs, and prescriptions. It emphasizes preventative care to improve overall health outcomes. While Medicaid offers extensive coverage, limitations do exist. Some services may require prior authorization, and not all providers accept Medicaid, which can affect access. Be aware of state-specific limitations and policies. What is Medicare? Medicare is a federally funded program that primarily serves older adults over the age of 65 and some younger individuals with disabilities. Its structure is divided into different parts and coverages. It has multiple parts, each covering different aspects of healthcare, with Part A and Part B being the core coverage options. There are also limitations of Medicare. It is not comprehensive, and some services may require additional coverages. Coinsurance, copayments, and deductibles apply. Limited coverage for long-term care and certain therapies, and certain services require prior authorizations. Beneficiaries often need supplemental insurance. It's important to be mindful of cost-sharing requirements and coverage gaps, especially for the long-term or custodial care. Medicare claims. The first step of the Medicare claims process is to ensure the clinic and providers are enrolled with Medicare via the PECOS or Provider Enrollment Chain and Ownership Systems. Once verified, the provider is enrolled and a claim can be submitted. To submit a claim, use CMS 1500 forms and submit electronically through the clearinghouse or Medicare Administrative Contractor, or MAC. You will submit CPT/HCPCS codes and modifiers for each procedure and task performed in your claim. Your documentation must be supported and medically necessary. Any changes can be made or adjusted to claims using the timely filing link for up to 1 year from the date of service. Third-party reimbursements come from insurers other than government programs such as private insurers, workers' comp, or liability insurance. These payers help cover costs and reduce patients' out-of-pocket costs. Billing must follow specific policies, and sometimes multiple payers coordinate benefits, which requires careful processing. Third-party reimbursements are vital for a balanced revenue cycle. The reimbursement process begins with the patient receiving services. Once services are provided, the provider will document, diagnose, and recommend treatment. This information will be submitted as a claim to the payer, whether that be through Medicaid, Medicare, or private insurers. The payer will review the claim for accuracy and review the patient's coverage. Once it is determined what is covered under the patient's coverage, a payment will be issued to the provider. This cycle highlights how clinical documentation and coding directly impacts whether providers get reimbursed. Accurate documentation is key. What is a PPO? A preferred provider organization, also known as a PPO, is a mechanism for negotiating discounts for employers that purchase health services. These types of health insurance plans allow for flexibility in provider selection for patients. A patient can choose any provider they'd like, but receive deeper discounts if the provider is within the PPO network. PPOs offer a list of PCPs that will bill at a lower rate to employers for a fee. Generally, PCPs contract with 5 or 6 PPOs. What is an HMO? A health maintenance organization, also known as an HMO, is a prepaid, comprehensive system of health benefits that combines the financing and delivery of health services to subscribers. HMOs have a list of providers that are available for patients to choose from. Patients need to establish care with a primary care provider, or PCP, to help coordinate their plan of care. Referrals to specialists are needed from the PCP. The trade-off for this more structured plan is lower premiums and out-of-pocket costs to the patient. What are the differences between PPOs and HMOs? While both PPOs and HMOs are insurance plans that fall under the umbrella of a managed care organization, or MCO, PPOs are more flexible in that they allow for a patient to choose any provider they wish and do not need a referral. Depending on if that chosen provider is in network depends on if the cost will be slightly lower or higher. In-network providers tend to be less expensive. HMOs are less flexible in that they have a list of approved providers to choose from. PCPs must be established, and typically direct care to other specialists with referrals is needed. With PPOs, costs tend to be less due to lower premiums and out-of-pocket costs. Contract negotiations are all about finding a balance between the provider needs and the PPO's goals. Some providers have better negotiating power based on things like providing care in less populated areas or those with historically good utilization rates. To the contrary, some providers have less negotiating power based on things such as practicing in densely populated areas with many providers. PCPs can negotiate for higher rates for a level 1 visit to utilize the code to its highest potential. According to our Beaupert textbook, helpful questions when evaluating PPO contracts include questions like, will I receive enough patients from this PPO? A PCP should get at least 1 patient per day from a PPO contract. Is the fee schedule acceptable for the codes used most often? It is important to check the PPO's fees schedule for the PCP's top 100 CPT codes that the PPO will divulge. Does the PPO require lab work to be sent out? This could cause loss of money to the clinics with in-house labs. Are the specialists the PCP is accustomed to referring to and the hospital in network? Referring to out-of-network providers means higher cost to the patients. Note on number 5 that a withhold is a portion of the fees withheld by the PPO for high utilization rates. Also note on number 9 that a hold harmless clause involves the PCP agreeing not to sue the PPO for certain actions or inactions pertaining to the PPO contract. As with PPOs, HMO contract negotiations are also all about finding a balance between provider needs and HMO goals. According to our textbook by Beaupert, there are several issues in an HMO contract that can be negotiated. Some examples include highlighting what is included in primary care services, defining the turnaround time between billing and payment for capitated rates, and inquiring if there is a requirement for specific office hours that need to be held, or if there is a coverage for hospitalized patients. You can also negotiate if there are bonuses involved, and if so, how often they are awarded. Negotiations can be beneficial for healthcare providers. Referrals versus consultations. A referral is made with the intent for the referee to manage care. The provider to whom the patient is referred bills an evaluation and management visit, not consultation, and continues to manage the patient's care. The intent of a consult is to advise. PPO consultation and referral fees are generally higher than those of an HMO. This is due to the fact that PPOs bill using fee-for-services, which allow NPs to bill separately for the services they provide. Fees vary based on the contract agreed upon, population, region, and services provided by the NP. PPOs allow for an NP to potentially make more as compared with an HMO. According to Faulkson and Srinivasan, HMO-specific referral and consultation fees for NPs can vary depending on the terms of the contract. Things that can affect these fees are location, population, and agreement. However, HMOs are typically more rigid than PPOs and have set fees that are predetermined. HMOs feature a network of providers that treat a patient population for a prepaid cost. HMO fees for referrals and consultations tend to be less than those of PPOs. An HMO consultation fee contract for NP may state something similar to, "We will pay the physician a sum of $5,000 per contract year, with one payment made on the date this agreement is signed and one payment made 6 months after the signing of this agreement, plus $200 per hour for consultation time initiated by the NP. Consultation time includes telephone consultations, in-person, face-to-face, and review of charts. The minimum segment billed for a consultation is 10 minutes. The nurse practitioner will pay consultation fees monthly within 30 days of receiving a bill from the physician. When patients are admitted to a hospital, the NP shall pay physician for consultation time until such time as the patient is admitted. As an independent clinic, we can also allow self-pay and offer payments on a sliding scale. There are also subscription models for primary care that nurse practitioners are experimenting with that involve a monthly fee paid for reduced cost services. It is important to set clear pricing and post fee structures, and patients should be told about charges up front. It is also important to take payments in a few different ways, such as cash, credit card, digital alternatives, or even via a payment plan. Affordability is something that often hinders those from seeking care altogether, so offering a sliding scale depending on income is available at some clinics. Thank you for reviewing the billing landscape for our primary care clinic in Cotter, Arkansas. By prioritizing proactive eligibility checks, accurate ICD-10 and CPT coding, and strict adherence to Arkansas Medicaid, Medicare, and private payer requirements, we can maximize reimbursement, reduce denials, and improve patient access in our rural community. Implementing consistent processes, ongoing staff training, and regular performance monitoring will sustain compliant and efficient revenue cycle management.